Welcome back to Stop Feeling Like Shit. And I'm your host, Daniela Korth. And today we have Dr. Buzz again, of
Hey
course.
there.
And we have Joe Matovich back in the house. Hi, Joe.
Hi. How you doing
Hi.
today?
All right. So we're just going to jump right into it. And the first topic of discussion is going to be cholesterol. Now,
Ooh.
yeah, I
Yeah.
know. Everyone is
Mhm.
like, oh, cholesterol, that's so bad. So let's start off first with what is cholesterol?
You want to go off? I mean, cholesterol, the way I kind of look at it, it's the building block of a lot of different tissues. Like when someone asks what cholesterol is, I always say if you're building a house, the cholesterol is like the mortar that holds the bricks together.
Mhm.
So we need cholesterol. But it gets a bad rap because they've set these figures, and if your cholesterol, everyone's really paranoid about high cholesterol. But you have to realize high cholesterol in certain situations is not bad, and we'll kind of go over that in detail today. But you need cholesterol. And I think a lot of physicians that aren't well versed in the space, as soon as someone comes in with high cholesterol without looking at any other markers, puts people on statins. And there's lots of really bad side effects to statins. And if you really look at the studies, I think if you look at all cause mortality compared to people with high cholesterol that get on statins to not being on statins, the death rate decreases 1% being on statins. 1%.
Yeah, I think if you look at the six largest, and yeah, what Buzz said, cholesterol is a essential structural makeup of our cell membranes, of steroid hormones, of the brain. But the average increase in life expectancy with statin therapy with at least 2 years of intervention, I think, is something crazy like 3.1 to 4.2 days, not
Yeah.
years, days,
And
right?
the quality of life. I mean, I always tell people like you'll never find somebody who's on statins that feels great. Never.
Right.
Because you need the cholesterol for your sex hormones. You need cholesterol. It has a lot to do with CoQ10 and mitochondrial function, which gives you cellular energy. Um, it has a lot to do. The brain's made up a large part of cholesterol, so there's a direct correlation to having chronically low cholesterol and dementia and other neurodegenerative type conditions. So I think you really need to be careful. Just because your family physician says you have high cholesterol, you're on the statin the rest of your life. You really need to do your own research and decide if that's right for you. And I'm not saying cholesterol medications are never needed, but I think they're way overprescribed.
Yeah, I think where they've shown to be the most statistically significant is in patients who already have a history of an existing cardiovascular event. Like, okay, I've had an MI, I've had a CVA, which is stroke, right? Um, there, and I would even argue that's from endothelial protective mechanisms, not directly modulating cholesterol itself. But those are the instances where it seems to be most beneficial, but it doesn't seem to be very effective in terms of preventative interventions.
No. And I think the big thing that's missed out on, Joe, and I know when people come to Buckeye, we test for this, there's more of a correlation to people that have systemic inflammation.
Right.
If you have lots of systemic inflammation, CRP levels are high, other inflammatory markers are high.
Homocystine's a big one.
Yeah,
Yeah.
which we test those, but
Yep.
most doctors don't. If those are high and you have cholesterol, that will tend to make the cholesterol stick to the arteries and can be problematic. But if you take down that systemic inflammation, then cholesterol just does what it's supposed to do and goes to the cells and the tissues and all the other stuff. So I think a more logical approach is if someone has high cholesterol, well, what's their inflammatory profile? Are they diabetic?
Right.
Because the diabetes is another thing. If you're diabetic and high cholesterol, you're gonna have high inflammation.
Right.
So yeah, you are more likely to have that stick to the arteries and different things where, there's lots of things we can do to bring down that systemic inflammation. Taking vitamin K2 is another one. Vitamin K2 ensures, because you need cholesterol for the bones and joints.
Right.
So you have people as they get older, you start having arthritis and you're on cholesterol medication, or we treat a lot of people that have disc injuries, chronic joint pain. If they're on statins, their outcomes aren't good.
Yeah. Well, so I think really what we're getting down and we're talking about when it comes to cholesterol intervention itself is what we're really most concerned with from a heart disease standpoint is what's the status or the health of the endothelium, that inner membrane of the blood vessels itself.
Hmm.
And that's what, when we talk to patients about cholesterol in the office, I said, think of the end of the endothelium. It's a single cell layer inside our blood vessels. Okay. And
Mhm.
that's kind of our protective barrier. And then you have the endothelial glycolics, which is kind of like a mucosal barrier. I don't know that that's a perfect explanation. I always say a healthy endothelium is more like a mattress, right? An unhealthy endothelium is like a sheet of drywall, and treat your cholesterol like it's a baseball. If I got a healthy, non-inflamed endothelium that's intact, the cell wall is healthy, you don't have other predisposing factors, unmanaged hypertension, diabetes, systemic inflammation. I'm bounce a baseball off of a mattress 1,000 times. I'm never going to throw it through there. I chuck a baseball against a piece of drywall, it's going to stick,
Right.
right?
Mm-hmm.
So when we're treating cholesterol, specifically in regards to cardiovascular disease, again, that gets back to, are we addressing the root cause? And if the root cause is really the status of the endothelium and whether or not it's predisposed to damage, like that's not what lowering cholesterol is treating. It's, it's trying to mitigate risk by stopping this N factor,
Yep.
but it's not addressing all of these comorbidities or all these lifestyle factors that make the artery susceptible to damage in the first place.
Correct. Yeah, and endothelial health, especially as we age, is very important. I call it like the canary in the coal mine. We see here a lot as males that start to have erectile dysfunction. Well,
Right.
Erectile dysfunction is the canary in the coal mine. If you have erectile dysfunction, you have endothelial dysfunction.
Yeah.
And you have more problems than that.
Yeah, that's peripheral vascular disease.
Yeah. So, that's another thing. So if you have that, and there are natural solutions, if you're willing to change your lifestyle a little bit, take certain supplements, do the proper testing, you don't have to be on a statin the rest of your life.
Well, I agree.
Yeah. So, and on top of it, we had mentioned earlier, I think I had read another study where, in 100% of people that were on statins, there's some level of loss of mental acuity,
Which would make sense.
which is crazy. 100%.
Yeah, especially with your older school statins that we know actively cross the blood-brain barrier, and then you start seeing cholesterol leaching out of the brain. Now, full transparency, there's some newer ones that don't do that as much, right? Which may be the cognitively safer version of that drug class.
Mm-hmm.
But some of the old school ones, I don't want to name any of them, but there are some older school cholesterol drugs. I don't care. Simvastatin is one of them. Used to have an 80 milligram dose. FDA has changed it and said the side effect profile with that dose is so high that as a prescriber, you can no longer prescribe it unless the patient was already on it before initiation of care. If it's a continuation of care, but the side effect profile was so abundant at high dose that you can't put a new patient on that drug at that dose. I mean, the drug still exists, just
Wow.
That's crazy. So I guess for people listening, and obviously when you go get your blood work done, and they come back and they say, "Oh, you have high cholesterol," right?
yep.
And then so one thing I hear him say is like, "Well, what's your triglycerides?"
Right.
Right?
Yeah. What's your triglycerides? What's your inflammatory markers?
Right.
Yep. And what's your HDL?
Yeah. What are you eating?
Yep.
Right?
So, yeah, go ahead.
No, you go ahead.
No. So, and that's one of the things that we look at when I'm reviewing labs with patients, because everybody's like, oh, I saw my cholesterol was a little high. Okay. Well, let's say your total cholesterol is 220, 240, but your triglycerides fasting are 35 or 40, and your HDL is 90. Your homocysteine is 5, right? Your CRP is undetectable. The rest of your metabolic profile, your A1C is good, you're a healthy weight, you're a non-smoker. I'm not losing one iota of sleep about your cardiovascular disease risk profile. Let's say patient B comes in, LDL is normal, right? Normal LDL cholesterol, which is your bad cholesterol.
Yeah, LDL is bad.
LDL is
good.
bad, HDL is good, and even the LDL is a little bit, people need to understand that not all LDL particles are atherogenic particles, which means you can have LDL that doesn't have the propensity to be atherogenic or cause atherosclerotic disease. There's more into it, like the characteristics of the particles and things like that really matter, that a normal lipid profile won't show. But if I took patient B that had a low HDL, high triglycerides, but a good LDL, and let's say their homocysteine 16 or 17, right?
And homocysteine is a marker of systemic inflammation.
Yeah, homocysteine, when we don't clear it out of our system, is systemically inflammatory, but it's particularly problematic to the cardiovascular system. In fact, we know a lot of patients with elevated homocysteine have a predisposed risk for vascular disease. Generally speaking, their baseline blood pressure tends to be higher because of endothelial inflammation that it causes. So
we're going back to endothelial health.
Right. So if I have somebody and again, that high homocysteine level, a lot of times is an indication of underlying genetic predisposition, like an MTHFR gene mutation, where we don't methylate B vitamins well, and then we don't have the B6, 9, and 12 that we need to break that homocysteine down and clear it out. So in regards to that lab reference, I'm going to take the patients with a high LDL, but great triglycerides, great HDL, normal homocysteine, over the person with high triglycerides, high homocysteine, and a normal LDL all day. The person with the normal LDL and the high homocysteine and high triglycerides are the person I worry about for two reasons. One, I know the homocysteine is going to cause endothelial inflammation, vascular inflammation. Two, their triglycerides high in a fasting state generally is going to be an indication that they're insulin resistant.
Mm-hmm.
Insulin resistance is a pro-inflammatory state of metabolic dysfunction as well, right?
Mm-hmm.
That's why their triglycerides are high, because of changes in hepatic processing of lipids. And we know that now they're going to have two inflammatory factors that make the endothelium susceptible to damage. So even though they may not have a ton of LDL, the endothelial barrier itself of the vessels is already more compromised because of its inflammatory or degraded status. So, there's a lot of nuance. Well, actually, I wouldn't even say there's nuance to that interpretation, but operating solely off of an LDL is really not an appropriate way to evaluate
That's the way
cardiovascular
most
risk.
people are managed.
Well, yeah, for sure. And even if you looked at cholesterol as a standard, even in standard of care medicine, cholesterol is one piece of the larger risk profile, right? So when we're looking at somebody who, from standard of care, American medicine, and I'm not talking about how we necessarily practice, other comorbid disease, diabetes and high cholesterol, or diabetes or high blood pressure, that's a risk factor. Obesity is a risk factor. Smoking is a risk factor. Sedentary lifestyle is a risk factor. Genetic predisposition for premature cardiovascular disease. So dad had an MI before 45 or mom before 55. And then coronary equivalents. Do you have chest pain? Do you get lightheaded when you walk upstairs? Do you get out of breath easy? And then elevated cholesterol is just one more risk factor. So cholesterol in and of itself, even by standards of care medicine, is not the complete picture of vascular risk assessment. In fact, standard of care even says if all of those other things are negative and you have high cholesterol, as a whole, you're still a low cardiovascular risk patient, right?
Mm-hmm.
But as soon as people see cholesterol is high, they're like, oh, I gotta bring that down, gotta bring it down, gotta bring it down, gotta take the statin. Like, well, hold on a second.
Yeah, I always tell people I feel like once you hit a certain age, it doesn't matter. You're going to go on one or two medications. If you're going to like a normal doctor to get blood work, you're going to go on a statin or you're going to go on a blood pressure medication.
Yep.
That's what I hear the most anyways, right?
Yeah, those are common.
So I guess for these audience, they're listening and they're like, okay, so number one, what I keep hearing over and over again is we have to reduce the inflammation in the body. Right? So how do people reduce inflammation in the body?
Well, step one is make sure you're going to a doctor that's actually testing for it, because most standard blood work doesn't test for inflammation. It's kind of crazy.
Right.
Because inflammation, or what they call inflammaging, like the term,
Right.
is the cause of a lot of disease processes.
Correct.
But they don't check for it. But that's something we do at Buckeye. And if you have those inflammatory markers, there's really 3 tests that we like to do to find. There's always a root cause. If you have a fire and you have these inflammatory cytokines, which are proteins that cause systemic inflammation, it could be really one of 4 tests. It could be a genetic methylation test, as you mentioned about, which is very simple. We do genetic testing in the office. In particular, the MTHFR genetic mutation.
Yep.
Those people there have issues with folic acid and methylation, which is very important. I really feel like that's one test every person should do once in their life.
Right.
Because your genetics never change. Once you do it, you do it.
Yeah, if you have it, you have it. And the good thing about those tests is, although methylation and different things, COMT, MTHFR, whatever iteration of methylation we're looking for that may genetically be abnormal, although the testing and the downstream consequences of them being off may be complicated, the fixes are relatively simple.
Yeah, we can't fix it, but we
But we
can
can
try to
treat
work
it.
around it.
Right. This is how it may be simple. It's like,
That's
you
one of
need
the 2
it.
things you can't fix.
Yeah, you need it. Yeah, but you know what I mean? The corrective intervention. Maybe, hey, these are a couple supplements.
And they're life changing for these people. When they change their lifestyle, they say, crap, I didn't really think I felt that bad.
Yeah.
And like COMT, I think is amazing too, because you have people that have had mental issues for a long time, and they'll be positive for COMT, and it explains why they've been mentally the way they are the whole life.
Right.
Which is crazy. It's almost like a sense of ease goes over those people. Like, oh, okay, I thought I was crazy. It's just a stupid genetic deviation I have. I'm going to do these certain things and whatever. So that's one test I think everyone should do. And it's a simple rub your cheek swab, whatever. I think testing your adrenals is essential, and in particular cortisol levels. In today's society, we never get a break. We're either working on our cell phones. Like no one takes a break, and kids are really bad with this too. I can't tell you how many teenagers we've tested, and their cortisol levels are through the roof. Cortisol raises inflammation in the body, decreases sex hormones, and you can see this in society, like, LabCorp just decreased normal testosterone levels.
Yes.
Well, they're going down because people's cortisol levels are going up, and cortisol is bad.
Right. And you think about, even if you want to go down that cortisol rabbit hole even more, you look at the influence of chronic stress on the immune system. The immune system is a driver of inflammatory processes as well. So there's the immediate effect of cortisol coupled with the secondary effect of immune dysregulation that comes with that as well, all of which are going to ramp up those inflammatory cytokines in your bloodstream, right?
Yeah.
And make you less adapt to heal and repair and get better. So
Yeah, and this is not a blood test you get at the doctor's office. This is a saliva test you do at your home, but your doctor's not the teenagers talking about, your doctor's not testing.
right. Well, and we talk about cortisol a lot in office with patients, where patients have had, maybe they had a blood test done. Listen, adrenal disease exists, but it's pretty uncommon, right? And I always tell patients, I said, listen, you don't have Addison's disease, you don't have Cushing's syndrome. Like, well, how do you know? Well, because they're not subtle. Your body doesn't make any cortisol. You're not going to live if you don't treat it. If you have Cushing's where it's sky high all the time, indefinitely for the entirety of your life, tachycardic, hyperglycemic, way pronounced overweight. Like, they're not subtle disease processes. So for us, in the middle grounds where we get that HPA axis dysfunction, we may see cortisol is transiently high for a short period of time. Maybe the diurnal pattern's broken. But when we're talking about functional disparities in the endocrine system and not an absolute disease state, a one-time-a-day blood draw doesn't tell us anything. Because you may have somebody who does an AM blood draw and their morning cortisol is fine, but their nighttime cortisol is 3 times the physiologic normal range. If we don't have all those data points, we don't know.
Yeah, so that saliva test the patient actually takes home, because you have to do it 4 times during the day. You have to check the rhythm of the day.
Yeah.
Which is very important, and we find that all the time where someone's like, man, I just have a hard time falling asleep, or I wake up at night. Well, you get that cortisol test back, and their cortisol is going up when they go to bed.
Yeah.
They're always going to struggle.
Right.
So, and that once again is something that's very easy to fix with nutrition and supplementation. You can reset those. So, these are all things that are fixable. And then that kind of leads to the next thing, because everything is related to everything, and that would be your gut and your microbiome. Most people don't realize the majority of the cells in your body live in the gut microbiome. Those microbiome and all those cells in there do lots of really important things. Obviously, we're responsible for digestion of food, absorption of vitamins and minerals. Your primary immune system is located in your gut. Yeah, when I say your gut, I'm just talking about your stomach. I'm talking about mouth to anus. That's your primary line of defense. A lot of your brain chemistry, serotonin, dopamine is produced there. So you have people that are on SSRIs or these other medications that their microbiome's a mess. They're not producing enough of those. So why not fix your gut to fix that instead of being on an SSRI?
Right.
And usually what happens is, kind of what happens is your cortisol's high, which takes your gut immune system down. So then you get parasites or infections, which kills off the normal microbiome. And I think it's important to know too, 80% of people that have microbiome issues don't have gut issues. Like, you're sitting here listening and say, well, I kind of go to the bathroom normally and my stomach's not, I don't have IBS. That doesn't matter. Most people don't have any gut symptoms.
Right.
You have all these other symptoms. And then really what happens is it develops into this thing called leaky gut, which everyone's heard of, but most people don't really understand what that is. But like literally, it's when the mucosal membrane basically opens up because the microbiome is not working properly because of infections and other stuff. And the food you eat literally leaks out into the bloodstream. That's where the systemic inflammation comes. Because, what happens if you eat protein and it goes right through the intestinal lining out into the bloodstream, the body doesn't know what the hell to do with it, so the body attacks it.
Right.
Yeah.
And that's what autoimmune disease is.
Right.
So anyone that has autoimmune disease is going to have leaky gut as the root cause. Now, autoimmune, you genetically have it, so I'm not saying...
Yeah.
But
But
it's
it
the
potentiates
fuel.
it for sure.
It's the fuel on the fire. So anyone that has any autoimmune condition, if they fix their leaky gut, the symptoms always get much better and sometimes go into remission.
Correct.
Yeah, I'm glad you said that, because a lot of people, obviously I'm on TikTok, and I see a lot of people that have a lot of autoimmune issues, right? And then they talk about, like, why won't my doctor do these tests that you're talking about? Because I was telling them about my story one day when I was doing my makeup. And I was like, I did, thank God, I did this blood work. Then after that blood work, we went did the testing. And they say, like, why don't my doctor offer these tests? They don't offer these tests. My insurance doesn't pay for this. So I know we're kind of like sort of getting off the topic, but I need
I
people to
mean,
understand that,
part of the reason is the interpretation is very challenging. Like,
yeah,
it took us, Joe, like literally over a year to kind of figure it out.
Yeah.
You can't put it in a textbook and learn in a semester at school. You
right.
can't.
Because doctors,
Well,
and like I say, these doctors, when you're in modern medicine, it's just they're not trained to do what we're talking about with functional medicine, right? Because one, they don't have the time. You're not going to the doctor and they just
Average
don't have the
doctor
time.
visits 6 to 7 minutes.
Right.
They
So they
don't
don't
have
have
time to go
time.
over an interpretation.
I mean,
They're
our consults are an hour, and sometimes I run long. Right.
Right.
You have to sit down and kind of peel, peel the apple or peel the onion.
Peel the onion, yeah.
Peel the onion.
Yeah.
Yeah.
Peel to something. Well, in allopathic medicine, traditional medicine is built for the diagnosis of existing disease states. We're not talking about a disease state yet. We're talking
Right.
about functional disparities within the endocrine system, within the immune system, within the gut, even at the cellular level that may not have manifested as a disease yet, but are contributory to.
Mm-hmm. Yeah. Wow.
Yeah. And everything's related to everything. So you really kind of put all the pieces together. And the way I like to explain people to, what in my mind blood work is, I'm a car guy, right? So blood work to me is like the check engine lights on your car. So, if it overheats, the red light comes on. If you're out of gas, the light will come on. But it doesn't tell you in between. Like, it doesn't tell you when you're getting ready to break down.
Right.
Where these tests we're talking about would be more like when you go to the mechanic and he puts a scan tool on it and tells you exactly what the problem is and what the root cause is before it gets there. But blood work is, I'm not saying blood works are useless. It's a great, I want check engine lights on my car.
Yeah. It's a great entry point.
Yeah, but if you really want to see what's going on with your health, genetic methylation, adrenal test, gut microbiome test, and then the final thing that I think is really, really important is testing your mitochondrial function. And mitochondrial function is getting more and more popular because your mitochondria is how your cells work. At the end of the day, that's how you take fat, carbohydrate, and protein and produce ATP, which is energy. So that affects your energy, your metabolism, everything. And the more they research this, 5 years from now, everyone's going to be talking about mitochondrial health, in my opinion. Like, it's because it's the key to your health.
Mm-hmm.
But there's no blood test that tests mitochondrial health.
Right.
That's where like organic acid testing and actually the meat screen test is a blood test.
Yeah.
That we'll have at the office real soon. That looks at your mitochondrial function to see how efficient are my cells.
Right.
And that's very important.
In modern medicine, when mitochondrial health generally stops at thyroid management.
Yeah.
Right. But I mean, how many people have we seen that have appropriately managed thyroids or not, or thyroid functions fine, but there's still strong evidence of mitochondrial dysfunction, right? And that's happening within the function of the cell itself at an even deeper level. But you're right, we're not seeing on blood, we're seeing in organic acids.
Yeah.
Yeah.
Which is a urine test. People do it once again, take it home, urine test, first morning yield. And that what's really cool about that test is it really, it comes back, it's like a 14-page report, but it tells you exactly
What you need.
are you digesting foods, do you have any toxicities, what's your brain chemistry, like there's a ton of information in that test that really paints a picture of what's going on deep inside.
Yeah, for sure.
So those are the 4 tests I would recommend to everyone.
Super easy to do.
Yeah.
I just obviously do all of them, right?
And just so you know, insurance does not pay for these things. Like, insurance does not pay for these tests.
Remember, insurance is for catastrophic events only.
Right.
All insurance works the same way. Everyone has car insurance, or at least you're supposed to. Car insurance doesn't pay to wax your car.
Right.
It doesn't pay for your, someone to clean inside of it or to put a clear bra on it. But if something catastrophe happens, it covers it. So when you have a heart attack, covered.
So then
These are more maintenance items.
correct.
So do you want to? So I always tell people, do you want to maintain your body, or do you just want to wait till it breaks and then be in panic mode trying to fix?
Right.
It's that simple.
Yeah, and a lot of people say, well, it's so expensive. But really, if you're investing into your body and you want to live a good, long, healthy life, right? And that's what you want to do, then it's not, to me, the expense is really not high at all.
All
Like,
you gotta ask
what is
yourself,
it? Like
when you go to the
$1,500 for the
doctor,
test?
when you go to your doctor, the people, who do you see in the waiting room, and do you want to be that way when you're that age?
Yeah, that's true.
When I go to the doctor, which I don't go that often, but the last few times I've been there, it's a bunch of people in walkers, wheelchairs.
Yeah,
They're not enjoying life. They're alive.
right.
So they might have an okay lifespan, but what's their health span? Are they really healthy? Are they enjoying themselves? Are they getting on the ground playing with their grandkids? The answer is no.
Correct.
So those are textbook examples of people that probably take statins, probably don't take care of themselves, do blood works. If something's really crazy, they would address it with another medication, but they're doing nothing to maintain it. And then same thing would happen to your car. If you bought a new car, never washed it, never waxed it, never changed the oil, it might last, but it's going to run like crap. Your
Right.
body's the same way.
Right. Well, this was a great episode. I like
Yeah.
talking about
Yeah.
cholesterol and statins because I feel like everyone's on a statin. All right, so if you're listening to this episode today and you have any questions about cholesterol or statins, we want you to throw it in the comments or message us. We'd love to answer your questions. Other than that, stay tuned because we have another episode coming with Dr. Buzz and Joe again. We love both these guys, right? All right, so see you around on Stop Feeling Like Shit on the next episode.